And our next presenter will be Carol Ott. And Carol, you have the floor.
Thank you. So my name is Carol Ott, and I am in the Department of Pharmacy Practice in the College of Pharmacy. And I'm going to talk to you today about a proposal that we put together in combination with nursing, medicinal chemistry, molecular pharmacology, and biomedical engineering, as well as sociology and economics had a little part in this. And what we're going to talk about today is more focused on clinical practice and away from bench research, and more toward the idea of substance use disorder treatment and how we can build a network of treatment that can be a model for communities around the country. So relative to the state of the problem, we all know, or we've really been missing something, right? That substance use disorder, specifically opioid use disorder, is a nationwide problem. And often existing treatment for substance use disorders and mental health disorders are very fragmented, or as we've experienced getting out into rural communities in the state of Indiana, doesn't exist at all. And so we have great deserts of areas that have a real lack of treatment. When individuals encounter the healthcare system relative to substance use disorders, it's usually at a point of emergency. And so we have a person who's overdosed or is in a mental health crisis, or it really is an emergent situation where they're not really prepared to even consider something like treatment. And the idea that somebody can experience an overdose type of situation or go through withdrawal from a substance, and that they will learn from that situation when they have a substance use disorder, is incorrect. The evidence base tells us it's more of the hair of the dog kind of idea, that in the moment it feels terrible. But as they think further about it, those cravings and the problems that they have don't lend themselves to treatment. And so how can we create a network where we access people at the point in time that they access the healthcare system, whatever that might be? The growing rate of overdoses, as I mentioned, is limited, or the response to it is limited in many rural community areas. They're especially devoid of services. And then again, stigma also plays a very substantial role in how we manage people with substance use disorders. So this was what our web portal would look like. And so you can see the community network web portal in the middle and all the things we'd like to have surrounding that, and how can we as university partners work with the community for this type of network. From the county jail and community corrections, where we know we need medication-assisted treatment, and the governor's office has come to us and said this needs to happen now, to peer recovery support services, community mental health centers, recovery houses, primary care, emergency care, inpatient and outpatient treatment, naloxone availability, drug disposal, syringe services programs, which we are fortunate to have in Tippecanoe County. And how can we bring those things together and also integrate them into a web portal using integrated data services to be able to manage that. So some of our research aims that I really want to talk through with you. The first one was support the assembly of this community-based network for transitions of care. Oops, sorry, what did I do? Help. I got it, I think. To support the assembly of this network for transitions of care. And so it's not just how somebody accesses the healthcare system, but what are they going to do when they need to move on to the next part of that healthcare system? And so it's not just about the emergency room services or the inpatient treatment services or the person on the street who encounters somebody who's overdosed and needs a dose of naloxone. Maybe they can administer that naloxone dose, but they're not really quite certain what to do after that. They may call 911, but can this person access treatment services? When we think about the jail, that's a place where we definitely have issues with medication-assisted treatment. We have people going into the jail getting no treatment whatsoever, not only for substance use disorders, but quite often for mental health disorders as well. And so it creates this vicious cycle. So we're really looking at this community network. Purdue Healthcare Advisors is already working on a network with the community here in Tippecanoe County, and then we with Boiler Works have been able to work with Purdue Extension to get out into the community to do training on medication-assisted therapy and naloxone therapy. The clinical consultation model was something we hope to develop in concert with the School of Nursing, as well as IU School of Medicine here at West Lafayette, to develop a model because we do have so many community resources here in Tippecanoe County. They're just often fractured from each other. And how can we build this model to include pharmacy, medicine, and nursing to be able to provide a model consultation service? The second aim was the development and implementation of sociological and economic research really focused on patterns of substance use and substance use disorder. one of the things that sociology brought to the table, that I've been a clinical pharmacist in mental health for 23 years. And one of the things that sociology brought to the table was something that I didn't recognize, and that people who are overdosing on opioids most commonly and die from those overdoses are between the ages of 35 and 55. And we spend a lot of time looking at youth prevention, and that's important. It really is important. But when you have an age range of people that are dying more commonly, why is that happening? Is it because they're getting pain medications on a routine basis? Or is it because they grew up in an era where sometimes substances were more available or freely available for use? We don't understand the reasons why, which is why the sociological perspective was very important. Our third aim was to discover and develop point of care testing, and working with biomedical engineering on this. And so I'm a pharmacist, right? I'm an academician by accident, almost. So the idea that somebody could produce a smartwatch that might be able to monitor respirations, if you know somebody's at risk of overdose, if somebody's using or potentially using in a community like ours, where we have fentanyl-laced cocaine and fentanyl-laced methamphetamine. Perhaps they didn't even know that they were consuming an opioid. And so you have this wristwatch, this smartwatch, that can tell us what they might be using and can tell us what that respiration rate is, and dial 911 or call emergency services or an alarm, let somebody know. The fourth aim, and the last point that I'll make, because I just got the 1 minute signal, is discovery and development of laboratory testing to identify and characterize substances of misuse here in our county, in the state, and further around the nation. And one of the things that we are most interested in is kratom. And this is a substance that you can buy freely on the internet. The graphic on the right, all the blue areas, most people are searching for kratom. That's the blue. Our state is still red, which means most people who did internet search look for heroin, but we know that kratom is increasing. We don't really know how much in our communities. That's all that I have for you right now. I think I'm done if anybody has any questions.
Does anybody have any questions?
I can definitely see the advantages of connecting to various networks and various types of service.
Uh-huh.
Are you looking at how to do this in the context of privacy issues and HIPAA and such?
Yes.
And how do you see sort of being able to take advantage of communication knowledge?
So clearly, protected health information and HIPAA is very important, and we do not have a national healthcare system, so we don't have a national type of database for this information. Purdue Healthcare Advisors is currently working on software that would connect different types of providers, and that's why the integrated data sciences, they were involved with us as well to look at that. The web portal was the other area where we had some degree of concern about privacy of information. It was more meant to be a clearinghouse for what kind of treatment beds might be available, what community pharmacies distribute naloxone, and those types of things that could be updated on a real-time basis. But it was absolutely a part of our consideration was privacy.
Someone with a timer right behind.
We've got time for one more question. Right there.
Have you considered working with the Indianapolis Public-Private Health Exchange group that's formed to actually get the whole community health information out of it?
Yes, so my practice site is Eskenazi Health in Indianapolis, so I'm very familiar with the health exchange that you're talking about. We did not look at it as it relates to this proposal, but we're aware of all of the health systems that are involved in that exchange of information. I'm very familiar. We have Epic at Eskenazi Health, but when I log into Epic and see a client, it pulls in, there's a section I can hit that pulls in information from other health systems, which is definitely something that we'd want to look at as this proposal would advance.
Carol, thank you so much.
Thank you.